Thank you for the introduction. So as she said, I am Sunny Norton and I'll be discussing genetic screening in pregnancy. I do not have any conflicts of interest or commercial support to disclose. So I'll be reviewing a broad, I'll be providing a broad overview of the main categories of genetic screening in pregnancy, which include cell-free fetal DNA for screening of chromosome anomalies, maternal serum screening, which at this point in our area typically is only performed for neural tube defects, and carrier screening. And I'll be reviewing each of these screening technologies, the current guidelines, and our practices here, as well as follow-up testing and recommendations for each screening test. So I know this was discussed a little bit in the last session, but to provide a general overview of the differences between screening and diagnostic testing in this setting, screening provides a probability of a risk. It is not a certain result. It's considered non-invasive with a blood draw typically. So there's no risks associated with that for a pregnancy and no risk of a miscarriage. Examples, of course, include cell-free DNA, maternal serum, and maternal serum screening for aneuploidy, for neural tube defects, and carrier screening. Diagnostic testing, on the other hand, is a more accurate type of testing. It's more comprehensive in that we can test for more conditions, and it provides a more certain result for the condition we are looking for. Diagnostic tests are invasive. And so there is a risk for a complication when diagnostic tests are performed, including a risk for a miscarriage. And the two main diagnostic procedures that we offer in pregnancy are chorionic villus sampling, or CVS, in the first trimester, and amniocentesis in the second trimester. In general, we like to kind of keep certain criteria in mind when we are considering what conditions we screen for and what conditions might be appropriate to add on to screening as we are expanding screening options. And so some of the main things that we think about are the frequency. Conditions need to have a relatively high frequency. Most genetic conditions are rare individually, but a relatively high frequency and a significant morbidity and mortality. We wouldn't offer carrier screening for an incredibly rare condition or an adult onset condition, for example. We often include conditions that have treatment or intervention available, and this might include prenatal therapies, but it might also just include prenatal choices, options to continue pregnancy, not continue a pregnancy, or other types of interventions. Screening needs to have a relatively high sensitivity and specificity. And the benefits of screening should outweigh the cost of screening. So really, really expensive tests are not going to be feasible. Screening should be relatively rapid. In pregnancy, we can't have a screening test that takes more than 3 or 4 weeks because timing is very important, and it needs to be widely accessible. It cannot be more complicated than a blood draw or a cheek swab. We want to make sure it's accessible to most individuals. A really brief history of prenatal diagnosis and screening. The first diagnostic procedure with amniocentesis was performed in the 60s, and then serum screening began with neural tube defects in the 70s and adding in additional analytes for aneuploidies in the 80s, and then adding in first trimester screening in the 90s. And each of these obviously increasing detection rates for what we were screening for. In 2007, ACOG recommended that all tests be available to all individuals, regardless of baseline risk, and cell-free DNA became commercially available in 2011. In 2022, the California Prenatal Screening Department switched from maternal serum screening for aneuploidy to cell-free DNA. So I'm going to focus this talk on this section of the talk on cell-free DNA. And essentially with cell-free DNA, what we explain to patients is that we are analyzing DNA from the placenta that has been absorbed into the maternal bloodstream. So we use, it's called cell-free DNA from cells that have lysed open and the DNA is free floating. Cell-free fetal DNA represents about 10 to 15% of the total DNA in the maternal plasma. And most of that is placental. Typically, DNA in the placenta and the fetus are the same, but not always. It's reliably detected after 7 weeks gestation, and most labs offer cell-free DNA after about 9 or 10 weeks of pregnancy. And the concentration of DNA continues to increase as the pregnancy progresses. So later in pregnancy, we see a higher proportion of cell-free DNA from the fetus or the pregnancy. There's a specific amount of DNA that must be seen. We call this the fetal fraction. A specific amount of DNA that must be seen from the pregnancy specifically in order to perform the analysis. If the fetal fraction is too low, there's not enough to do the analysis or get the result. There are two main methods of cell-free DNA, and both of them do use next generation sequencing, but I'll very briefly review these. The two main methods are this MPSS, which is massive parallel shotgun sequencing, also referred to as the counting method, in which non-specific amplification together with next generation sequencing is used to sequence and then count all cell-free DNA fragments. Abnormal amounts of DNA from specific chromosomes of interest, like chromosome 21, relative to reference chromosomes, can then be identified. So if we find all of the fragments of DNA for chromosome 13, 18, 21, and there is more for chromosome 21 than the other two, then we are suspicious of an extra chromosome. The other method is a SNP-based platform, and SNPs are single nucleotide polymorphisms, so small genetic differences, kind of like a molecular fingerprint. And this provides a more targeted approach by only analyzing regions of interest, aligning fragments to chromosomes of interest, and comparing the differences between the patient and the pregnancy DNA fragments. And the main difference between these two platforms is that they can sometimes give us slightly different results or information. So with SNP-based sequencing, we can get a screening result for triploidy, which we cannot get with the other technology. Sometimes we are able to differentiate if a specific abnormality might be maternal or fetal. And with SNP-based sequencing, we can also determine zygosity in twin pregnancies, which can be helpful in certain situations. So there are several limitations of cell-free DNA. It is definitely considered screening, not diagnostic, and does not replace diagnostic testing. It is very accurate, but is not a replacement for diagnostic testing. It only at this point really screens for the most common aneuploidy, so trisomy 21, 18, and 13, as well as sex chromosome aneuploidies. Some labs are not able to perform cell-free DNA in certain situations, and this has changed a little bit, but with multiple gestations beyond twins, or in a pregnancy where there's been a vanished twin, sometimes cell-free DNA is not available. The data on cell-free DNA in twin and triplet pregnancies is more limited, so we don't have precise statistics on accuracy or sensitivity or specificity. And insurance coverage is still somewhat uncertain, but that is improving based on guidelines recommending that this is offered. Some patients still have a larger out-of-pocket cost. So when we're thinking about the overall accuracy of cell-free DNA, since it is a screening test and not diagnostic, it's helpful to consider certain parameters, most specifically positive predictive value, or PPV, which tells us the chance that a screen positive test is a true positive result, that there is truly an affected fetus. And this table on top, which is taken from an ACOG practice bulletin, shows how maternal age, essentially disease prevalence, can affect a positive predictive value. So For example, in a situation where we have a 20-year-old with a positive cell-free DNA result for trisomy 18, the PPV is somewhere in the range of 11 to 41%, meaning the chance that the pregnancy is actually affected with trisomy 18 is potentially as low as 11%. However, in a situation where we have a 40-year-old with a positive cell-free DNA for trisomy 21, the positive predictive value is much higher in that situation, in the 90% range, 91 to 99%, depending on the lab and other factors. So this kind of demonstrates that the same test, the same technology, which was usually just reported as a high-risk result, it might actually have very different implications depending on other factors in the pregnancy. And the bottom graphic here shows that in just another form from an ACOG patient handout, showing what positive predictive value might be depending on a low or high risk patient. Comparing this to what might be listed on a lab report, when labs report positive predictive values and they provide standard positive predictive value measurements for all conditions, they are basing that off of general population, clinical validity within their lab, and maybe large published population studies. And so it's still accurate, but it's not patient specific. So you can see that they would report a positive predictive value for trisomy 21 of 95%. That might not apply to a patient who is 20 years old with no family history or ultrasound findings. So these values are helpful for us to keep in mind the accuracy of the testing, but they might not be patient specific, which is important for counseling. You can see that the positive predictive values for sex chromosome anomalies is lower in the 80%. Triploidy, the positive predictive value is quite low, 7%. So pretty big range here. And this kind of leads to our challenges when we want to expand the menu of conditions for cell-free DNA. Obviously, we want to screen for more conditions if it makes sense, if we're able to find more pregnancies at risk. And we do offer screening for some microdeletion conditions, and some labs offer screening for many microdeletion syndromes, or even broader genome sequencing. But there is overall limited data on the sensitivity, specificity, and positive predictive value for that. And you can see the positive predictive value for some of these microdeletion conditions can be quite low. So for Prader-Willi syndrome, for example, it's 5%, which is quite low. And that can be challenging if we're counseling a couple who comes in with a positive screening result. They might think they have a very high risk, and it might not be as high as they were anticipating. At this point, the only microdeletion that is recommended to be offered to pregnant patients routinely is 22q deletion syndrome. So when we have a patient with a positive screening result, there are specific steps we follow. So first, they're referred for genetic counseling. Typically, we would obtain a very detailed family history and determine if there's anything in the family that might be suggestive of some sort of inherited chromosome anomaly. We would offer follow-up ultrasound depending on the gestational age. If we have a patient at 11 weeks, we can offer them a nuchal translucency ultrasound or a first trimester early anatomy scan to try to get as much information as possible. And then, of course, if they're later in pregnancy, we would be offering a second trimester anatomy ultrasound. We would also offer diagnostic testing by CVS or amniocentesis. And if a patient declines diagnostic testing and they determine that they would continue the pregnancy regardless of the diagnosis and they do not want an invasive procedure, we might offer them a fetal echocardiogram. For certain chromosome anomalies that we're concerned about, the testing might differ a little bit. So for trisomy 21, 18, 13, or triploidy, we would offer a CVS or amniocentesis, and we would offer a karyotype to look at pictures of the chromosomes and confirm or rule out that diagnosis, as well as if it's a chromosome problem that might be inherited. For sex chromosome abnormalities, there are some studies that show that there is a higher rate of placental mosaicism, meaning the placenta itself might have cells with extra missing X or Y chromosomes that are not present in the fetus. We call that confined placental mosaicism. It can happen for any chromosome problem, but we see it a little bit more frequently with sex chromosome abnormalities. And so if we have a positive cell-free DNA result for those conditions, then we might recommend amniocentesis over CVS. And for any microdeletion condition, specifically 22q deletion syndrome, we would offer a microarray, which can be performed from CVS or amniocentesis as well. Each of these tests have about a 2 to 3 week turnaround time. And in some situations, we can offer a preliminary result looking at direct preparation from CVS or a FISH analysis from amnio. We get a preliminary result in maybe 2 to 3 days. It might provide us some more information, but it's not as comprehensive. So in 2016, ACOG released a practice bulletin stating that prenatal genetic screening and diagnostic testing options should be discussed and offered to all pregnant women, regardless of maternal age or risk of chromosome anomaly. And they state that cell-free DNA is the most sensitive and specific test for common aneuploidies, but is not equivalent to diagnostic testing. This was reaffirmed in 2018. The guidelines further state that screening for microdeletions is not at that time recommended, as it's not been validated clinically. Genome-wide cell-free DNA, same, it is not recommended, as the data on that is still limited. And cell-free DNA for single gene disorders, which is available through some labs for certain conditions, is not at that time recommended as well. And the guidelines haven't changed, so at this point, these are not recommended to be routinely offered, though they are commercially available. In California, we have the California Prenatal Screening Program through the California Department of Public Health, and they offer cell-free DNA through specific contracted laboratories, screening for certain conditions. So trisomy 21, 18, 13, and sex chromosome aneuploidies, and they can provide fetal sex as well. For any positive results, patients are offered follow-up, like I mentioned previously, at one of our clinics, a perinatal diagnostic center, and that follow-up is not charged to the patient or their insurance. It's paid for by the public health department. And there's other kinds of results that patients can get that we might still offer follow-up for. 2 failed results in a row, they might still be eligible for follow-up services. Specifically, services would include genetic counseling to review the results, ultrasounds, and prenatal diagnosis by CVS or amniocentesis. So because of the challenges in different labs offering different screening tests, we like to look to professional organizations for guidelines on what we should be offering and kind of trying to be consistent with that and evidence-based. So ACMG recommends cell-free DNA over traditional screening methods for all pregnant patients with singletons pregnancies for trisomy 21, 18, 13, and sex chromosome abnormalities. They recommend cell-free DNA for twin gestations as well. They recommend screening for 22q11.2 deletion syndrome, but not other microdeletion conditions at this time. They recommend pre and post-test genetic counseling, or counseling in general, and offering diagnostic testing with a positive screening result. So at Stanford, what we currently offer patients, if they have not had any screening, we would offer them cell-free DNA per the guidelines through a commercial lab. If they have had cell-free DNA through the California Prenatal Screening Program through their OB, we would offer what we call supplemental cell-free DNA, which would look for the additional conditions that have not yet been screened for. Since it's recommended that these specific conditions be offered to all patients, we want to make sure that patients know they have the option to do additional screening that might have not already been performed if they would like, but certainly they can decline additional screening. So some challenges that we currently face with cell-free DNA, we can still see failed results, atypical results, low fetal fraction, Insurance coverage still somewhat uncertain. It is difficult to determine which version of cell-free DNA should we offer. Do we want to offer as much as possible or kind of stick to the things that have a higher detection and positive predictive value? Um, should patients still be having a nuchal translucency ultrasound, which was traditionally part of serum screening, but could still provide additional information? Um, it is still considered screening, requiring diagnostic testing to confirm results. And some patients have some confusion around this. When they get that screening result, they think there's such a high accuracy, it must be correct. And it can be difficult to explain that we do still need to confirm it. We can see false positives. And there is some difficulty in screening pregnancies with multiples or vanished twins. Some labs offer this, some do not. So we do get false positives, and we can get no call or failed results frequently, and those can be challenging from a counseling perspective. So some causes for that. So a low fetal fraction can lead to a failed result, and this can be influenced by a patient's BMI, early gestational age, and other maternal factors. Vanished twin can lead to false positive results or failed results. A maternal chromosome abnormality, if a woman herself has a chromosome anomaly that might not be identified, that can complicate the results. Maternal conditions, including fibroids and maternal malignancy, have been associated with atypical results. Confined placental mosaicism, which I mentioned briefly before, where there's chromosome anomalies in the placenta, but not the fetus. That is one cause of a false positive result. Fetal chromosome anomaly outside the scope of the test. Some labs will say that there was an atypical finding. Maybe they're seeing a chromosome problem on another chromosome or a deletion that is not within the scope of the test, but they still provide some information about it. Sometimes if there's egg donors or gestational carriers, that can lead to DNA technical difficulties in providing a result or interpretation. And maternal history of a recent blood transfusion or organ transplant recipient would obviously also complicate the DNA pattern that the lab is analyzing. Some labs provide more specific interpretation for atypical results, which can be helpful rather than it just saying atypical result or failed, which is hard to know where to go from there. Some labs provide more information. They might state if they might think it's a maternal chromosome anomaly or mosaicism, if the finding was below the level of threshold, which might indicate fetal mosaicism or placental mosaicism. If, again, the potential chromosome abnormality is outside the scope of the test, if there's an interfering signal from a maternal or fetal DNA copy number variant, so extra missing piece of chromosome, and they might provide the specific chromosome of interest. Here's an example of an atypical result. There is a result for trisomy 21, 18, 13, and triploidy. There's no result for monosomy X, and they write that there's an atypical finding on sex chromosomes outside the scope of the test, which may include fetal mosaicism, fetal chromosome abnormality, or normal variation. So this tells us there might be an X or Y fetal chromosome anomaly, or it could just be variation in the DNA. It's a little bit of information. It's not a ton to go off of, but fortunately in this example, there is low risk results for the other conditions. When we get an atypical or failed test, again, offer genetic counseling and family history and pregnancy history. If they've had a history of recurrent pregnancy loss, there might be a maternal or paternal chromosome anomaly that we want to look into. We would offer a nuchal translucency ultrasound or anatomy ultrasound, diagnostic testing. In certain situations, we would consider a redraw if there was a low fetal fraction, or we can consider a redraw through another lab with a different methodology to see if there's any new information, emphasizing to the patient it is still considered screening and we could still miss something. In certain situations, we would consider a maternal karyotype or microarray to identify a potential maternal chromosome anomaly. And if there is unusual results showing potentially multiple aneuploidies, we might consider a workup for the patient for potential concern for malignancy. There's not strong guidelines here, but those are things that we would consider. So here's a case study. Patient's 41 years old. She's a G7P2 and has had 4 miscarriages. She's referred for cell-free DNA with an atypical finding on sex chromosomes, stating that the atypical finding involves the X chromosome and is suspected to be of maternal origin and appears to be mosaic. They report that in 94% of the patients with this result, there will be a sex chromosome anomaly. So it's very detailed. We did get a low risk for the other conditions. The patient was 5'2", had a reported history of a heart murmur, hypothyroidism, depression, no history of learning disabilities or other significant medical history, and elected maternal chromosome analysis for herself, declined diagnostic testing. A karyotype for her revealed that she had 47XXX. So this was, at this point for her, 41 years old, an unidentified chromosome anomaly. She was never aware she had this. So we are giving her this diagnosis kind of based on an incidental finding of her cell-free DNA. For her specifically, she appreciated having this information. It hadn't really affected her. It didn't feel like a huge new diagnosis for her. She found it interesting. So in this situation, it was, it had a good ending, I guess I could say. Here's a second case study. We have a 20-year-old G1P0. Her cell-free DNA was drawn at 10 weeks based on her LMP, maternal weight of 115, and she has a result that states there's a high risk for triploidy, trisomy 18, trisomy 13 due to a low fetal fraction. So this laboratory provides an actual risk for those 3 conditions when the fetal fraction, the maternal age, weight, and gestational age meet certain criteria. And they say that risk is 1 in 17. She was seen for genetic counseling. We reviewed the different causes of low fetal fraction, including maternal weight, early gestational age, normal variation. We offered diagnostic testing and an ultrasound. And the ultrasound showed that she was actually much earlier in pregnancy than originally thought. Her EDD was recalculated, and we determined that her previous cell-free DNA was just drawn too early. So she had it redrawn, results came back negative. So this result had been alarming for her. It looks like a high risk for potentially very severe conditions, but in her situation, it was a low fetal fraction, not due to one of these conditions, but due to other factors, specifically that she was just too early in pregnancy for there to be enough DNA. So I'm going to switch topics. I'm going to start talking quickly since I want to stay on track. But a little bit of maternal serum screening. Traditionally, maternal serum screening was offered for aneuploidy, including first and second trimester blood work and nuchal translucency ultrasounds. And at this point, we're really just doing that in California for AFP because the state screening program offers cell-free DNA instead. And with serum screening, we use multiples of the median. So this is a way to provide a unit that corrects for other differences within a laboratory, and we can have sort of standardized units that we're looking at. And the reason we switched is because of the higher accuracy and detection rate with cell-free DNA, as you can see here for trisomy 21 and trisomy 18, significantly higher detection rate for cell-free DNA versus the other forms of serum screening. We do still provide screening for neural tube defects and ventral wall defects with AFP, which is a protein produced by the yolk sac, GI tract, and liver. It increases in the second trimester until weeks 30 and 32. So we measure this between weeks 15 and 20. Typically, it's most accurate between weeks 16 and 18. And an increased AFP is associated with neural tube defects, open spina bifida and anencephaly, ventral wall defects such as gastroschisis. Really high levels can be associated with renal concerns such as Finnish nephrosis. Abnormal AFP is also associated with placental insufficiency and risks for pregnancy complications, including fetal demise. We use a cutoff of 2.5, and it has a detection rate of 80 to 90%. There are factors that can affect these levels, and we confirm all of these during genetic counseling because we have seen patients where they come in with positive results for AFP, but we have incorrect information for them. Their weight was written incorrectly, Twins and we didn't know about it, smoking or diabetic status, these can all affect it. And if those are reported correctly, sometimes it can change the results. So when a patient has a positive AFP, we provide genetic counseling and discuss all of the possible etiologies, including neural tube defects or ventral wall defects, as well as things that can cause a false positive. So twin gestation, incorrect dating, bleeding in the pregnancy. So other things that can result in a high AFP. We obtain detailed medical and family history, offer an ultrasound at 20 weeks specifically, or as close to that as possible. And then we offer amniocentesis. And with amniocentesis, we can look at amniotic fluid AFP and acetylcholinesterase, which increase the detection rate for neural tube defects to about 98%. If everything is normal on the ultrasound, then we follow the pregnancy with growth scans and recommend non-stress tests due to the concern for adverse pregnancy outcome. All right, so the last section of the talk will be about carrier screening. And traditionally, carrier screening has included, like what was originally offered was cystic fibrosis and spinal muscular atrophy to all patients, as well as a CBC, including an MCV to screen for hemoglobinopathies. Ethnicity-based carrier screening was also traditionally offered. And then it switched a little bit to pan-ethnic screening, so offering a carrier screening panel of disorders to all individuals regardless of ethnicity. And then what we called expanded carrier screening, which was a larger panel of disorders, which previously was not routinely recommended, but has had some change. We've seen some changes in that. So a review of some of the disorders that we're kind of screening for, the inheritance patterns. So we're mostly screening for autosomal recessive conditions, which occur when both individuals in a couple carry the same genetic change, and they could pass that down. If two individuals carry the same recessive condition, there's a 25% chance to have an affected pregnancy. If one individual in the couple carries it and the other does not, then 50% chance to have a child that's a carrier as well, but we're not worried about an affected pregnancy. Our carrier screening panels also include some X-linked conditions where we screen to see if the pregnant patient or female is a carrier, and if so, 50% chance to pass that down, and males are usually more severely affected than females. Females might be asymptomatic carriers. Previously, carrier screening specifically for cystic fibrosis was done with genotyping, looking for the presence or absence of specific common variants, but now we primarily do sequencing, reading the exact sequence of the gene, which increases the detection rate and allows us to find more rare variants that might be less common in the general population. So in 2021, ACMG released a practice resource stating that carrier screening should be ethnic and population neutral, and all patients who are pregnant or wanting to become pregnant should be offered what they call Tier 3 carrier screening for autosomal recessive and X-linked conditions, 97 recessive and X16 X-linked genes. And this screening was based on information including general population frequency, so conditions that had a carrier frequency of 1 in 200 or more were included in this, and had a moderately severe phenotype. So the prior recommendations of a higher frequency of about 1%, they were wanting to expand that to try to offer screening for more conditions and try to evaluate couples who might be at risk, and missed with more ethnic-based carrier screening approaches. So just kind of a brief overview of some of the differences in ACMG, ACOG, and NSGC guidelines. ACMG recommends this total of about 112 disease carrier screening to all couples. And then we can expand on that if there's a specific family history of a genetic condition or couples who have consanguinity. ACOG has a different approach. They recommend that all couples be offered carrier screening, and that is dependent on the carrier screening approach that the provider would like to use, but it needs to be consistent with all patients. So they can offer ethnic specific, pan-ethnic, or expanded carrier screening. It should be the same for all patients. And all patients should be offered cystic fibrosis, spinal muscular atrophy, and screening for hemoglobinopathies. Additional screening should be made available if requested or if family history warrants. And at Stanford, we offer the ACMG panel to all patients and then expand on that depending on family history or consanguinity. If a patient has a positive carrier screening result, we review family history, disease and clinical features, discuss risks that family members might be carriers, and offspring might be carriers. If there's any risks to a carrier, we would review that, and we would offer carrier screening for the partner. We would offer them single gene carrier screening or the full panel. If a partner is not available for carrier screening, or both individuals in the couple are found to be a carrier, then we would offer prenatal diagnosis for the specific variants that we've identified. If diagnostic testing is declined, then we offer ultrasound if there's anything that might be detected, usually not. We discuss the availability of newborn screening if it's on the newborn screening panel, and we recommend that the pediatrician be notified. We talk to patients about the option of IVF with pre-implantation genetic testing in a future pregnancy if they are interested in that information. So some kind of general carrier screening considerations. If parents are carriers for the same condition, we would offer diagnostic testing or postnatal testing recommendations. Panels vary between labs. Most panels have wide ranges. Some panels are 14 genes, some are 600. So there's a really wide range of gene panels available, and not all of them contain the genes recommended by the American College of Medical Genetics. Screening does not detect all genetic variants. So any negative carrier screening result, there will be a non-zero residual risk. There will still be a residual risk for the patient to be a carrier or for the pregnancy. It is not 100%. It is not looking also for all recessive conditions. We would always still consider family history if there are conditions in the family that are not on the panel or specific variants that might not be detected with the panel. Testing for partners can be done in parallel, so we can offer a couple testing at the same time. We'd get results back in about 2 to 3 weeks, or some couples prefer to start with one individual and then test the partner only if something is identified. That's fine. For billing purposes or just anxiety purposes, some couples choose one or the other. So some other notes on carrier screening. In general, how often do we perform this testing and find that somebody's a carrier? Some reports state that the carrier frequency of a positive result might be as high as 55% with this 113 disease panel. But the chance that both individuals carry the same condition is much lower at about 1 or 1.5%. Some conditions are variable. They might have more or less severe forms, and some families or couples don't want to know about certain conditions or would want to be thinking about that in the pregnancy. That perspective is obviously very broad. Some conditions have less well-defined phenotypes. We might not be able to provide a lot of anticipatory guidance on what to expect in certain situations. Some patients say, well, I don't need to do any carrier screening. I don't have anything like that in the family history. So some counseling that these can still be present. Most of us carry some genetic conditions. We talk a lot about that. And then being a carrier of certain conditions might increase the risk of developing certain conditions or symptoms. For example, individuals who are Fragile X syndrome carriers are at an increased risk for premature ovarian insufficiency and tremor ataxia syndrome. So when we're talking to couples about carrier screening, we might say that we might find a result that could impact some of your medical care or recommendations for you, just so we have given them a little bit heads up around that and we don't catch them by surprise. And I think in the interest of time, I will stop there. I do have a case study, but I can stop there in case there are questions.
Hi, Sunny. Yes, thank you so much. I appreciate your taking this opportunity to share this information and to be in the same space with you. So we do have some questions. And one question is from the Q&A. It says, why or how does BMI influence fetal fraction?
Yeah, so what I usually explain to patients is that in individuals that have a higher BMI, there is a higher proportion of their own maternal DNA, which then decreases the fetal DNA in relation to that. So it's an increase in the maternal DNA, which then decreases the fraction of fetal DNA. Which can be a sensitive topic if we're talking to individuals who maybe have had failed tests, and that's something that is kind of sensitive to discuss, but that's how we usually describe it.
Thank you. Another question is there a reason why partner carrier screening hasn't become a routine part of prenatal care? Seeing those genetic schematics makes me wonder why we place so much emphasis on the birthing person.
Yeah, that's a really good question. I would say that some ordering providers don't have a system set up to order testing for individuals that aren't their patient. Insurance might not cover things as well if it's not a pregnant individual. Um, Ideally, we test both individuals of a couple at the same time because we get results back at the same time. And if I have results that says one individual is a carrier of a genetic hearing loss and the other is a carrier of cystic fibrosis, they're not carriers of the same thing. You get that result at the same time. It's much less anxiety provoking than having to wait another 2 or 3 weeks. So ideally, that's what's done. We have partners that don't have medical insurance and they don't want to pay for the testing unless they actually feel like they need to because the pregnant patient is a carrier. So there's different reasons I would say why some partners decline or kind of want to hold off. I know there's certainly situations where the pregnant person says, well, I'm getting my blood tested for all these things anyways, just like add one more thing on. But I agree that there's not the system support. We should be offering it to both individuals and a couple routinely.
Thank you. There's another question that says, these are such complicated concepts. What tools do you use to explain this concept to patients with limited health literacy?
That's a great question. So in genetic counseling, we very traditionally use a lot of visual aids, and that can be really helpful if somebody has learned this information at some point in biology class in high school or junior high, and I can kind of pull back from that just a little bit. That can be really helpful. Individuals that might have not had that education or didn't learn about that, using a lot of visual aids can kind of help support that. And then we have individuals with a lower medical literacy or literacy in general, and visual aids sometimes is not helpful. And so we, fortunately, in genetic counseling, our sessions are quite long. We have usually 45 minutes or an hour, so we can really take our time. Interpreters, obviously, when we need them to review things as best we can. And we usually review things in multiple ways or even in multiple appointments to make sure that we are getting the information across without overwhelming the couple.
Thank you. One comment and question is, many of the discussions you have with patients and families are very alarming and exceedingly stressful for them. I know you well. I know how compassionate you are and how you go above and beyond to help these families. What resources do you have to help support families going through difficult diagnoses in pregnancy?
Mm. Thank you. I mean, I'm lucky to work with a large team where we have multiple providers that can help situations and families and situations from multiple perspectives. So if a couple is looking for answers on what to expect for a pregnancy, we connect them with neonatology or certain specialists to kind of find out as much information ahead of time as they can. We utilize social workers as best we can and local parenting support groups, pregnancy loss support groups. So we try to just kind of pull in as many resources from within Stanford or our community here on the Central Coast as possible. And some individuals utilize those well, and some are a little bit more hesitant, but trying to just let them know that we are supporting them in any decision that they want to make. They want testing, they don't want testing. And we kind of can help them through the pregnancy. We don't have to be a one session and we're done situation. And just get them as connected to as many resources as possible.
Transfer it over to Nalima to ask the last two questions.
Have you noticed any differences in patients' decisions for invasive testing before and after that 2022 change in the California state screening recommendations?
That's a good question. So I work in the Salinas PDC, and just kind of historically, our patients are a little bit more risk adverse, and often we have many patients continuing pregnancies with high risk results and not pursuing prenatal diagnosis in general. That being said, we have seen, I would say, since the adoption of cell-free DNA in general back in 2011, and then like more largely in 2022, 2021, I would say that yes, we have seen a lower lower number of procedures being performed because patients are just starting with a more accurate screening test. So what might have been a false positive serum screening result, patients are then just kind of getting straight to the cell-free DNA, and we might be seeing less false positives. On the other hand, we have a very accurate screening test. And now if the screening test is coming back positive, instead of some couple saying, well, I'm going to do another screening test, they are also just going straight to a diagnostic test. So I guess there's different reasons why we've kind of seen some dips. But overall, I would say less prenatal diagnosis since we've been using cell-free DNA.
Okay, thank you. With patients undergoing IVF or in vitro fertilization and known pre-implantation genetics, is there still value to adding that additional cell-free DNA testing, and how do parents perceive that?
Thank you for that. Yes. So pre-implantation genetic testing, whether it's for aneuploidy or for specific single gene conditions, is still not 100% accurate. So the same testing that's available in a spontaneously conceived pregnancy is recommended in pregnancies with IVF. We offer the same exact tests. Some couples obviously are hesitant to pursue amniocentesis when it has taken them so long to get pregnant and they've gone through IVF. That can be really complicated. And some couples just choose to not do that. But everything is still offered because pre-implantation genetic testing is not guaranteeing that none of these conditions are present.
Okay. And then last question, has anyone looked at sort of parental anxiety with these kind of large carrier screenings, right? Because, and you presented that one case too, where the mother was unaware of a diagnosis, and now all of a sudden you are slapped with a diagnosis. So has anyone actually looked at that systematically?
That's a great question. I'm not aware, kind of off the top of my head, of any specific studies. But I think that we do discuss that in our counseling for these carrier screening tests, where I think kind of, originally cystic fibrosis testing was just kind of offered to everybody with variable amounts of counseling. But if we're testing for 100 conditions, we do kind of want to make sure they know how will they feel with a positive result and what will they do with that information? And we kind of walk them through that to kind of consider, you know, it is considered optional, and it's okay for couples to just say they don't want it. If they feel like that might cause them anxiety and they would not do anything differently with that, it's not something that has to be performed. So we try to discuss that. But I think that's a great question, and I'm not aware of specific studies, though that it's possible that there are some.
Okay. Thank you so much. This was an excellent session.